3, 2, 1. Sir, we are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Lung Cancer Management 2020. With immense pleasure, I would like to invite Dr. Rahul Sood, who is Consultant Medical Oncologist, Command Hospital, Bangalore, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you very much for the kind introduction. So I've been given this opportunity to introduce today's topic, which is on lung cancer. So why lung cancer? And the answer to this is why not lung cancer? Because lung cancer happens to be the commonest cancer among males in India. It is the third most commonest in females in India. And if you see the mortality, that is the death because of lung cancer, it is the highest in the males as well as the females. So it is a very, very important and pertinent problem. And as we go forward, we see that more and more cases of lung cancers come into being. This is mainly because of the smoking, though it has gone down in the male population, but it remains a problem in the female population. Initially, when the lung cancer started, it was the squamous cell carcinoma which was predominant. But our studies have now shown that now the adenocarcinoma is the commonest cause of lung cancer in India. When we started our practice in oncology, we found that the only way we could treat lung cancer was either in the form of surgery, radiation, or chemotherapy. More so in India, we find that majority of the cases of lung cancers which we encounter come in the advanced or the metastatic stage. That is, the cancer would have already spread beyond the lung, either to the bone or to the brain or to some other organ like the liver or the adrenals. So therefore, majority of the cases that we come across are the stage 4 cancer or the metastatic lung cancers. The treatment paradigm for metastatic lung cancer used to be only chemotherapy, which was a platinum-based chemotherapy, cisplatin or carboplatin, with either pemetrexate or with gemcitabine or paclitaxel. But what the problem we used to face was, though there used to be some initial response, but there was always a lacking response that was seen in the individuals. That is, majority of the times, the patient used to just relapse or progress even while therapy. So this was a major problem. So what we started was molecular testings in lung cancer. That is, to find molecules, to find targets which can be easily targeted by some form of therapy. Therefore, the treatment of lung cancer started to shift from chemotherapy to targeted therapy. The first target that was found out was the EGFR, or the epithelial growth factor receptor, which played a major role in the proliferation of the cells of lung cancer, thereby also causing dissemination of lung cancer. So this was a potent target which should have been blocked. With the advent of the EGFR, we found that there were molecules that were developed which were anti-EGFR in the form of first generation TKIs or the tyrosine kinase inhibitors like gefitinib and lotinib. Going to the next version, that is the second generation TKIs like the afatinib and the dacomatinib, and then finally the best TKI that we find in our practice, that is the third generation TKI, which is the osimertinib. These alone or in combination with chemotherapy have changed the paradigm. That is, not only the primary was being controlled, but also the metastatic site. So over a time period, the lung cancer has evolved many folds, and there are so many updates that we get every day. So it is pertinent on our part to know about the updates in lung cancer, what are the changing paradigms which are there, and what are the best drugs that is there. So I will kickstart today's evening on lung cancer by these few words. I hand over to the organizers to set the ball rolling and introduce the speakers. Thank you.
Thank you so much, sir, for your beautiful insights. And without taking much time, I would like to introduce the first speaker, the first talk for the day on the topic lung cancer management, what physicians need to know. And the renowned speaker is Dr. Narayanan S., who is a ranked Lieutenant Colonel and pulmonologist at Command Hospital, Bangalore. Over to you, sir.
Thank you very much for your kind introduction. And thank you, Dr. Rahul Sood, for a wonderful prelude on the lung cancer. Mine is a very important topic, which is about diagnosis of lung cancer. As you all know, in our country, with tuberculosis remaining very prevalent till now, it is a great masquerade for diagnosing lung cancer, because it is easy for a physician to start a patient on anti-tubercular therapy, especially when he finds any opacity in the lung which is persistent. Since there are overlap between the symptoms and signs of both lung cancer and tuberculosis, the physician feels easy to start an ATT, labeling the patient as smear-negative pulmonary tuberculosis, and giving an ATT means you're fixing a diagnosis for a patient for the next 6 months. If you don't follow up the patients, you delay the diagnosis of lung cancer for the another 6 months. With this introduction, I'll start presenting my slides. There are over 2 million people diagnosed with lung cancer each year, and 1 out of 5 diagnosed people will be alive after 5 years of diagnosis, which means approximately 1 out of 5 cancer deaths among the total cancer subset is lung cancer, and every minute 3 people die from lung cancer. This statistics is from Globocan, which is a platform, the web-based platform the WHO has introduced, wherein all countries are supposed to register their patients. I mean, it is not compulsory, but they have a database wherein they present the statistics. This is of 2018 vintage. It is not very old. So one out of 5 patients will be alive after 5 years, and the leading cause of cancer deaths across the world is lung cancer. So this is Globocan 2020 data. Total number of lung cancer incidents in the year 2020 was 88,831. Among those deaths of the total cancer deaths, around 80,000 people died of lung cancer alone. And with around 9.3% is the incidence per death of lung cancer. The less patients diagnosed at earlier stages, not to blame anyone, the patient presents to you late only because the symptoms as he starts coming in only after stage 2, stage 3. By the time the patient presents to you, he is already in stage 3 or stage 4. So when you compare males versus females, the statistics doesn't differ. Around 30 to 40% of patients present to you when they have undergone a loco-regional METs. Most of the patients, both males and females, around 45 to 50% present to you when they have already got a distant metastasis. So what is the tumor classification? How do you classify lung cancer? You have broad classification is around small cell lung cancer and non-small cell lung cancer. The most common is a non-small cell lung cancer, which is around 80 to 85%. Among the non-small cell lung cancer, around 20 to 25% is a squamous cell carcinoma. As already Dr. Rahul Sood has said, adenocarcinoma forms around 40 to 50% out of the non-small cell lung cancer. And large cell carcinoma is around 10 to 15%. Other types like a carcinoid, a salivary gland tumor, an alveolar cell carcinoma, all those other types, a sarcoma, forms the other types of cancer which are not very common. Coming to the presentation of lung cancer, we already discussed. The presentation is quite similar to an tuberculosis, a persistent or deteriorating cough and hemoptysis, hoarseness of voice or wheezing when the RLN is involved, a fatigue, weight loss, a dull aching chest pain or a pleuritic chest pain, a breathlessness on exertion, and loss of appetite, pretty much same as tuberculosis. diagnosing lung cancer is pretty important. When you suspect a lung cancer, you have three broad modalities where you can go ahead and diagnose. One is do an imaging, a CT scan. First is a chest X-ray, then followed by a CT scan, and then a PET CT scan if it is indicated. Thereafter, you go and sample the tissue because you need to classify as to which head the patient goes to. A non-small cell lung cancer or a small cell lung cancer. Even if it is a non-small cell lung cancer, especially when the targeted therapy has come in, you need to identify whether it is adenocarcinoma, squamous carcinoma, or an adenosquamous carcinoma. You have to go ahead and perform an immunohistotyping, and thereafter a FISH or a gene sequencing to identify whether those mutations which Dr. Rahul spoke about exist in the patient or not, because the management differs when the patient is classified into one of these diagnoses. So laboratory tests include all those which I have already said. So when you diagnose lung cancer, you can go ahead and do a needle biopsy when the lesion is present in the peripheral 1/3 of the lung. If it is in the central 1/3, the medial 1/3 of the lung, you go and do a bronchoscopy, take a tissue, brush biopsy, or a cell block doing a bronchial wash, and an EBUS for both diagnosis and staging of lung cancer. If the center has got EBUS, or most of the centers now has got an endobronchial ultrasound. So why the lung cancer is being diagnosed late? Misdiagnosis most of the times, as the symptoms mimic the other respiratory diseases. In our country, tuberculosis number one. Now with COVID and post-COVID symptoms have started setting in, we have more of the patients with a diagnosis of COVID, and then on follow-up they are being labeled as a post-COVID symptom rather than investigating them for a lung cancer. A lack of screening in high-risk patients, especially patients who are reformed or ongoing heavy smokers. You need to have a screening protocol in our hospital, but we don't have anything, and lack of awareness, of course, on patients. So patients with warning signs and symptoms of cancer were misdiagnosed as tuberculosis to the tune of around 20%. This paper came in from All India Institute in the year 2009. So 4.03 months were the patient was on anti-tubercular therapy. Thereafter, these were the median months the physician took to diagnose a lung cancer. So to the tune of 20%, 20% was misdiagnosed as tuberculosis, despite the warning signals were present. The mean age was around 58 plus minus 7 years, smokers 12 out of 14, smoking pack years of more than or equal to 44. So across India, these are the various studies right from Karnataka, Uttarakhand, Tamil Nadu, Jammu and Madhya Pradesh. So these studies also said the same thing. The number of patients misdiagnosed were to the tune of around 23% to around 43%, where in Jammu it was around 43%. The median diagnosis to the symptom delay was around 3 months. So what is the solution? So awareness is the solution. To create awareness to the physicians treating a chronic lung disease is the solution. And of course, the patient comes next, the awareness to the patients. So AKT should not be started. That is the bottom line. Without confirmed diagnosis. Any chronic respiratory symptom with any opacity in the lung, it is easy, very easy to label as tuberculosis and start the patient on ATT. We have to restrict ourselves, especially when we don't have a microbiological diagnosis. If the sputum is negative, we need to go ahead and take a sample. As I said, the medial 1/3 lesion should go for a bronchoscopy, or a peripheral 1/3 lesion should go for a CT-guided FNAC biopsy before the patient is being started on ATT. You need to have a tissue/microbiological diagnosis before the patient is placed on ATT. Because once you start ATT, you're delaying the diagnosis for about approximately 4 to 6 months. Careful monitoring should be done in all those who are smear negative, and despite all investigations, if you go ahead and start ATT, please do follow these patients, every month, if not every 2 months. Consider lung cancer as a differential diagnosis, even if the patient is a never smoker, especially when there is a persistent opacity which do not resolve with the anti-tubercular therapy. So lack of screening in high-risk patients, we'll speak about in the next coming slides. It is not existent in our country, and lack of awareness is also an issue. Symptoms include cough, hemoptysis, fatigue, patients more than 50 years of age, smoking history. So, these are the symptoms of lung cancer. The screening techniques for lung cancer, you can go ahead and screen them in a chest X-ray or a sputum cytology or a low-dose CT scan. Chest X-ray is very non-specific. There are studies which have been done on screening techniques with chest X-ray, which didn't show any mortality benefit. Sputum cytology, again, it is a difficult thing to do. You have to induce the sputum, especially when the patient presents here with the dry cough, and the lab has to be trained in diagnosing malignant cells on a sputum cytology. Again, not recommended, not useful. Low dose CT scan, yes. What is the evidence? The low dose CT scan, before going on to the evidence, I'll just tell you it is around 20 milliampere seconds. 25 to 40 milliampere seconds. Conventional would take around 115 milliamperes. Is just the X-ray film dose. The CT scan dose, and seconds is the amount of period of exposure of the patient. So it produces satisfactory image quality. Of course, it's better than the chest X-ray. Reduces the CT dose index, and that thereby maximally protects the patients from a radiation exposure. Hence, preferred for multiple scans as needed. So this is the National Lung Cancer Screening Trial published in the NEJM in 2011. The study was around included around 53,000 patients between year 2002 to 2004. They were divided into two subgroups. One was made to undergo a chest X-ray. Second was to a low-dose CT scan. And you can see the results. Relative reduction in the mortality was around 20%, which is quite significant with a p-value of less than, equal to 0.004. So NLST found that for every 320 low-dose CT scan administered, one life could have been saved, compared to 864 tests for a colorectal cancer, which we go ahead and do colonoscopy for all those patients, between 645 to 1,700 scans for a breast cancer. So this is the Nelson trial, which was done in the Netherlands and Belgium. This is high-risk patients, that is smokers, more than 30 years of, more than 30 pack years of smoking and more than 55 years of age, undergoing screening at baseline, T0 and year 1, year 3 and year 5.5 versus no screening, follow-up of 10 years. The cumulative ratio for death for lung cancer at 10 years were 0.76 with a p-value of equal to 0.01, again very significant. So NCCN came up with this lung cancer screening guidelines based on these two trials. They were divided into group 1, group 2, high risk group, a moderate risk and a low risk. High risk group 55 to 77 years with more than or equal to 30 pack years, and group 2 involved around more than 50 years and more than equal to 20 pack years. They recommended that the candidates for screening shared patient, you have to discuss with the patient, and the patient physician has to discuss and arrive at a decision. Discussion including a discussion of benefits and risk, and a low-dose CT scan, if the patient agrees, is always recommended for these high-risk groups. Moderate and low risk, the lung cancer screening is not recommended. The risk factors: smoking history, secondhand smoke exposure, family history of lung cancer, occupation exposure, radon exposure, cancer history. Especially a patient with COPD is again more prone to lung cancer, even if you remove the smoking risk as a cause for lung cancer. So a physician play an important role in the early diagnosis of lung cancer, especially in patients with respiratory symptoms not responding to antibiotics, in our country anti-tubercular therapy, chronic smokers, a family history of lung cancer, and a cautious reading of chest X-ray. Even a 5 to 10 second extra time in looking at a chest X-ray in a busy OPD schedule, especially when the patient has got more than 30 pack years of smoking, is fruitful in diagnosing those small lesions which are not visible when you just look at an X-ray. So screening identifies suspicious nodules less than 5 mm. You can always, these are Fleischner Society. There are Fleischner Society guidelines. This is a general guideline. 5 mm are NCCN guidelines. 5 mm are small. Next dose CT should be, low dose CT should be around 12 months. 6 to 7 mm in 6 months. 8 to 14 in 3 months. If it is 15 mm and larger, it is always recommended to do a PET CT scan. Also, in addition to probably doing a tissue diagnosis, either with a CT guided thing or a bronchoscopic technique. So early treatment, we all know it. Early treatment will lead to better survival. If you diagnose the patient in stage 1A1, the 5-year survival is 92%. Vis-a-vis stage 4B, it is less than 1%. You can see the declining 5-year survival rates when the patient progresses higher in his stages. So issues with I'm just concluding. The issues with lung cancer screening is no screening guidelines for smokers. Again, we need to develop institute-based guidelines, depending on the caseload, for non-smokers also. And of course, smokers, at least a chest X-ray, spending a little more time on a chest X-ray is important. Cost effectiveness, again, is debatable, especially in developing country like India. You need to discuss with the patient. The solution is having a robust screening guidelines. Each institution can have its own guidelines, and physicians be aware of the patient's they can refer for lung cancer screening. Lack of awareness, you need to discuss with the patients and create awareness. These are the various societies in India creating awareness. The way forward is we have already discussed. A good artificial intelligence-based algorithms can detect better those opacities than a human eye, both in CT and chest X-ray. And thank you very much for giving me this opportunity. Questions will be answered at the end of the presentation. Thank you.
Thank you so much, sir. And I request everyone to post their questions in the chat box so that we can keep the track of time. Now, I would like to invite the next speaker, Dr. Prasad Narayan from Bangalore. Dr. Prasad is a senior consultant medical oncologist at SiteCare Hospital, Bangalore. And the topic for his talk is newer paradigms in resected EGFR early lung cancer. Over to you, sir.
Hi, good evening. Am I audible, visible?
Yes, sir.
Yeah, so I thank Dr. Rahul for this opportunity, and thanks specifically to include the first talk actually, because we usually our meetings we don't discuss the basics things, and it is important to know that as well and to discuss that as well actually, and the awareness that many patients are missed because of assumption of COVID and all is so important. So I will be focusing basically on a paradigm shift which has happened in the treatment of resected EGFR mutant early lung cancer. So we heard about this. About 85% of all the lung cancers are non-small cell lung cancers, as Rahul and our previous speaker has explained to us. And my specific topic, that is 1/3 of these patients, if you take stage 1B, stage 2, and stage 3A, where we treat with a curative intent, stage 1A, hardly we see, they present with a resectable disease. So, and still in this group of patients who undergo a curative intent treatment, the cure rates, 5-year recurrence rate is around 45% in stage 1B, 62% in stage 2, and 76% in stage 3, which means that we need to go a long way in terms of curing these patients really in a meaningful manner. And any treatment which can actually help in this regard is welcome. So we have gone through the treatment, different types of options, and the main focus of today's talk will be the EGFR mutant group. So when you look at the different stages of cancer, we know that EGFR mutant lung cancer, there is a huge improvement by treatment with the EGFR anti-EGFR therapies, and the prevalence of EGFR mutation is almost similar in all stages, which is important. Stage 1, 2, 3, 4 across the Asian, US, or European population, it is similar as in different stages. So definitely, if we have an EGFR anti-EGFR based therapy, which can actually be tried in this group of patients and that can result in a better outcome, that is always welcome. That was the basis of the ADAURA trial, which will be the topic of discussion today from my side, which looked at osimertinib as adjuvant therapy in the curative intent treatment of EGFR mutation positive NSCLC. So it's a very simple design. Curative intent lung cancer patients all should have exon 19 deletion or L858R mutation. And these patients should have undergone a complete resection with negative margins. And if the patients had adjuvant chemotherapy, which almost 60% of the patients in the study had, the randomization should be within 10 weeks. And if it was without adjuvant chemotherapy, it is 10 weeks. And with adjuvant chemotherapy, to include that within 26 weeks. Stratification based on stage and the type of the mutation and race were given 3 years of osimertinib, 80 milligram per day, or placebo. And the study was designed with an assumption of a hazard ratio of 0.70 with disease-free survival as the primary endpoint. So it is important to note that the assumption was that we will get a hazard ratio of 0.7. I'm saying this because we will see what happened in the study. So inclusion criteria, pretty simple inclusion criteria, straightforward inclusion criteria. And the baseline characteristics, if you see, the male-female ratio, age, the smoking status, ECOG performance status 0 and 1, then the adenocarcinoma versus others, EGFR mutation, the type, and adjuvant chemotherapy were equally balanced. So well-balanced study in both arms. Large study, 600, almost 700 patients with 350 in each arm. So this was the primary endpoint, that is the disease-free survival. If you take overall population on the right hand of the on the screen, the hazard ratio was, I don't have to say the hazard ratio because it is so significant. The curves are so wide. Hardly in any solid tumor study, especially in an adjuvant setting, we get this kind of curves actually. So the hazard ratio, which was expected to be for positivity 0.7, it was almost 0.2 in the overall population. It was a definitely positive study. And there was an interim analysis because of the improved outcome, and the data was presented. And if you take the slightly higher stage, that is stage 2 and stage 3A, it was even better. There was an 83% reduction in risk of disease recurrence or death, the hazard ratio being 0.17 in this group of patients. So the study definitely met the primary endpoint. And this is the 2-year DFS. It was consistent for osimertinib stages. In stage 1B, 88%, stage 2, 91%, stage 3A, 88%, which means that regardless of what is the stage of the disease, the benefit of giving osimertinib definitely is there across the stages in this group of patients. And the subgroup analysis, when we look at it, there is nothing to choose actually. There is no single group of patients who did not benefit. It is a clear benefit towards the test arm. The osimertinib has demonstrated better outcome regardless of the different subgroups, based on whether the EGFR mutation, which type was, or whether patient received adjuvant chemotherapy or not, or the stage Asian, non-Asian, etc. This is the overall survival curve. It is not a mature curve, so I don't think we can discuss much about that. We will not discuss about the hazard ratio of this curve because the overall survival is not mature. And we hope that with this much improvement in the DFS, we should get an improvement in overall survival. And with the present generation of adjuvant therapy approvals, I think it is a straightforward decision to approve this treatment in EGFR mutant patients post-resection. Now, to give a background and to say how important this data is, we can look at the other studies actually, because this is not the only EGFR and EGFR therapy which came. So we were keenly looking at these studies when they were happening and they got published, the erlotinib and the gefitinib studies, because the magnitude of improvement in resected lung cancer with chemotherapy is not very big. And we all thought that if you are giving an anti-EGFR therapy for EGFR mutant patients, we may improve survival over chemotherapy. But these studies, whether it was erlotinib or gefitinib, had never shown an improvement in DFS in EGFR mutant group. And that is the importance of the ADAURA study, and that is precisely why the expectation was to get an DFS improvement with a hazard ratio of 0.7, and we got an improvement of around 0.2, 80% improvement actually. So another thing is about to look at the type of recurrence. So local and regional recurrences are associated with a longer post-recurrence survival in any cancer. And CNS definitely is one of the common site of distant recurrences. If you look at the adjuvant study with erlotinib, 37% of the patients recurred in the CNS. And we all know that osimertinib is a significantly better drug to in CNS positive patients, and it prevents CNS disease in advanced patients as well. So in the ADAURA study, the type of recurrences where distant recurrence was seen in 61% in the placebo arm versus 38% when we use it in the osimertinib arm. So definitely distant recurrences are much less when you use osimertinib, and we do specifically take the CNS recurrence, which is our area of interest, because CNS recurrences is almost with detrimental outcome in a patient, regardless of whether there are single met or multiple metastases. So there were very less CNS recurrences. It was 1% versus 10% with osimertinib. And if you see all the CNS DFS events, overall 45 patients and 6 in the osimertinib and 39 in the placebo arm had CNS recurrences. So CNS recurrence rate is much less in the patients who received osimertinib, and that is shown in the curve as well. So safety summary, osimertinib definitely is a very safe drug. We all have experience in using in advanced cancer, and this study in the adjuvant setting also proved the same. If you take any adverse event, it was not much of difference between the osimertinib versus the placebo. And let us look at specifically the grade 3 and 4 toxicities. Hardly any grade 3 and 4 toxicities we can see. Grade 1 and 2 toxicities, diarrhea, the GI side effects were the predominant ones, which is seen with most of the EGFR TKIs, and osimertinib is no exception, but it is not grade 3, 4, so it is manageable. The other one, the QTc prolongation, grade 1 and 2 interstitial lung disease, these are all seen in small percentage of patients, and nothing much to say about the safety. It's a safe drug in this group. Now, let us look at the chemotherapy use, whether there was a difference in the patients who received chemotherapy or not. From the forest plot, we know, but this is a separate analysis and a publication which came out of that. So 60% of the patients received adjuvant chemotherapy in both the arms. Majority of them received platinum-based therapy, mostly the ones who had stage 2 or stage 3A disease. And in stage 1B, only 1/4 of the patients have received adjuvant chemotherapy. So what is the difference in DFS with adjuvant chemotherapy or without adjuvant chemotherapy? The impact of osimertinib is there regardless of the whether the patient received adjuvant chemotherapy or not. 89% versus 49% with adjuvant therapy, and without adjuvant chemotherapy again 89 versus 58. So the impact of giving osimertinib post chemotherapy, or if the patient doesn't get chemotherapy, is there, and EGFR mutant patient definitely should be discussed about this option of treatment to improve the DFS. And if you see if you take this stage-wise grouping and see with and without adjuvant chemotherapy also, everything is in favor of osimertinib in this study. So this is the graphical representation of the same statement in stage 1B, stage 2, and stage 3A. Regardless of whether the patient received adjuvant chemo or not, there is an improvement in outcome by adding osimertinib. Now, when you have an adjuvant study and we have this kind of DFS improvement, another question that will come will be the quality of life. So this is the quality of life publication. So there was this was based on a health-related quality of survey assessment, and 85% of the patients actually completed this survey, which is important in an adjuvant study where there were around 700 patients. That is important because that gives us more information. Now, the quality of life survey there was no deterioration in the physical or the mental assessment. There was no reported deterioration by giving adjuvant osimertinib in this group of patients. So health-related quality of life was equal in both the group of patients. So in summary, adjuvant osimertinib, the first targeted agent to show a statistically significant and clinically meaningful improvement in DFS in stage 1B, 2, and 3A EGFR mutant lung cancer patients. There was an 80% reduction in the risk of disease recurrence or death, which is significant statistically. And the 2-year DFS rates were 89% versus 52%, and the curves were widely separate. So that is why it is clinically also meaningful. And there was an improvement in the CNS DFS as compared with placebo. The safety profile was consistent, and it was regardless of the role of whether the patient received adjuvant chemotherapy or not, the health-related quality of life was maintained. So in summary, adjuvant osimertinib will provide a highly effective practice-changing treatment for stage 1B, 2, and 3A EGFR mutant lung cancer after complete tumor resection. And that is the new standard of care in this group of patients. Thanks a lot.
Thank you so much, sir. For the next talk, I would like to invite Dr. Murli Subramaniam from Bangalore. Murli is a senior consultant medical oncologist at HCG Hospital, Bangalore. And the topic for the talk is establishing osimertinib as SOC in the management of EGFR positive and NSCLC real world evidence. Over to you, sir.
Thank you. Am I audible? Slides are visible?
Yes.
Yeah, okay. Thank you very much for the invitation. Thanks, Dr. Rahul, for the invitation. Prasad, you have set very high standards like Virat and probably Rohit Sharma with hazard ratios of 0.17 and 0.1, 0.20, very high standards of hazard ratio. That's the magic of osimertinib in the adjuvant setting. Let's move on to the metastatic disease, where actually this drug was initially approved, and then slowly now we are seeing its benefits even in the adjuvant setting. The whole topic of discussion would be on the real world evidence of osimertinib in EGFR mutant metastatic lung cancer. The background is the FLORA trial. As we all know, that was the pivotal trial which brought in the approval for usage of osimertinib in first-line metastatic non-small cell lung cancer or EGFR mutant. So, and as we have discussed, osimertinib is an irreversible third-generation EGFR TKI. From the FLORA trial, what confirmed was an improvement in the median progression-free survival, 18.9 versus 10.2. The comparator arms were erlotinib and geftinib, erlotinib at 150 and geftinib at 250 mg, and a benefit in the median overall survival at 38.6 for the osimertinib arm and 31.8 for patients receiving the comparator EGFR TKI. So this is the background study, FLORA trial, which is the pivotal phase 3 trial based on which the osimertinib was approved in the first line setting. We quickly run through the key inclusion, exclusion, and how the study was conducted. It is very important to look into the pivotal study before we go into the real world experience. Here, the key inclusion criteria, what we look at is the performance status was 0 to 1. So most clinical trials will have stringent inclusion exclusion criteria. So hence, not all the patients will actually benefit from the drug. So you're looking at specific mutations at exon 19 deletion and 21 L858R mutation, and stable CNS metastasis was allowed in the study. It's a simple randomization 1:1 with osimertinib 80 milligram daily versus the comparator at geftinib 250 or erlotinib 150 milligram. OS was the key secondary endpoint, and PFS was the principal endpoint. So if you look at the baseline characteristics, they were well matched for sex, age, race, CNS metastasis. It's very important. Only 6 to 7% of patients had CNS metastasis, but we all know that in practice we do see more number of patients with CNS metastasis. That's how this real-world data helps us to understand how this drug works, even in those patients who have CNS metastasis with poor performance status also. Here, WHO performance status 0 and 1 were allowed, and only EGFR mutation 19 and L858R were allowed. So the forest plot. Of course, this forest plot doesn't look as attractive as the one which Prasad presented with hazard ratios of between 0.1 and 0.2. However, nonetheless, this is a metastatic setting. This drug showed benefit in virtually all segment of patient population, like from age being less than 65, greater than 65, Asians or non-Asians, whether the patient is smoking, whether CNS metastasis is present or not, whether the PS is 0 or 1. So irrespective of any of these, all patients started to benefit, giving a median PFS of 18.9 months versus the comparator arm was at 10.2 months. So this was the analysis on the overall survival. The median OS was at 38.6 versus the comparator arm was at 31.8 with a statistically significant p-value at 0.046. So conclusion, so this was the pivotal FLORA study which actually brought osimertinib in first line as a first line EGFR TKI monotherapy to show a statistically significant OS and PFS benefit in those patients who harbored a EGFR mutation for exon 19 and L858 or mutations. So of course there is always restrictions from the pivotal trial because of the strict inclusion-exclusion criteria. Based on this study, this study was approved as the frontline therapy as a preferred option in EGFR mutant for those who as an initial therapy, or in those patients who already chemotherapy has been initiated, osimertinib can be started after completion of chemotherapy. So how do we look at the real world? Many times we won't get patients who exactly fit into the inclusion-exclusion criteria of what we see in the FLORA study. So there are 3 published study for osimertinib in this clinical setting, which is the FLOWER and the OSI FACT and Mykonos, which actually kind of gives us confidence to go outside the inclusion-exclusion criteria for which is actually there in the FLORA study, and gives confidence that even in the most poor prognostic patient, this drug actually works. So first we look into the FLOWER study. This is again,
Murli sir, sorry to intervene. Yeah. Your voice is not at all clear, sir.
Okay. I'm on Bluetooth. Is it audible? No.
No, it's fine, sir. Yeah.
Oh, it's fine. So this is an introduction which basically talks about the FLORA final data. It also shows that only 2 to 4% of patients with cancer receive treatment with randomized controlled trials. Thus, raising a pertinent issue of representativeness. Are you representing all the patients? So this real-world data have become useful to us to assess unique insights in routine oncology practice in the post-marketing setting. So it gives us a broader horizon of the molecule outside the inclusion-exclusion criteria of the trial. Now, this study, there were 126 patients, which looked at the median age was 68. Brain metastasis was present at 30% at diagnosis, and then stage 4A were 23% and 4B were 71%, and bone metastasis at diagnosis was present in about 45%. So the best response to osimertinib in this study of 126 patients is a partial response, which is around 73%, stable disease at 23%, 5% or 4% of patients actually progressed in this real world study. So these were the key inclusion exclusion. So the standard inclusion exclusion criteria, 3B and 4 were included. EGFR, 1 or more EGFR mutations in exon 18 to 21. So the uncommon mutations were also were included in this trial. And there were slightly different endpoints compared to the FLORA. They used an endpoint called TTD, MTTD, which is basically median time to discontinuation of osimertinib therapy. As we all know in clinical practice that radiological progression, especially when there is an oligometastasis, very minimal asymptomatic progression, we tend to give some kind of local therapy and then continue with the TKIs, osimertinib, and thereby you actually end up giving these TKIs longer than actually the patient would have received in the clinical trial. So TTD is an actual exploration of this pragmatic real world endpoint rather than a radiological resist progression, which is actually looked at in the clinical trials. So the primary response, so patients with poor performance status, comorbidities, rare EGFR mutations, active. So most of the patients in the FLORA trial should have a stable CNS metastasis. Here, patients with active brain metastasis were also included. This is actually an exclusion in the FLORA trial. So outcomes from this study were similar to the published data, thus adding consistency to the osimertinib efficacy. So that gives a lot of confidence to us that the published data, which is actually in a restricted population, is actually which can be used for an extended horizon. So there was no difference in the PFS, TTD, and OSS were noted in elderly patients, patients with comorbidity, and even in the less common EGFR mutation. The biggest doubt or challenge we had is what happens if we have uncommon mutations. This drug actually works in real world experience, even in those who had uncommon mutations. So the primary assessment, if you look at the effectiveness time to treatment discontinuation, that is TTD, was median was at 25.3, whereas the PFS in the FLORA was around 19 odd months. So you get this additional 4 to 5 months of benefit. When you look at time to treatment discontinuation, it was at 25.3. If you look at from two other important points, that is one from in a symptomatic versus an asymptomatic, the median TTD was not reached in an asymptomatic patient, whereas it was at 18.8 months for a symptomatic patient at diagnosis. If you look at less than 3 metastatic sites at diagnosis, the TTD was not reached for those with less than 3, but it was at 21.4 months for those patients who had more than 3 metastatic disease sites. So this is the conclusion of the effectiveness. So outcomes were similar to the published data, thus adding consistent to the osimertinib efficacy. So the TTD was longer, like 25.3 months than the post-progression outcome analysis of the FLORA. FLORA was around 20.8 months. This gave an additional 5 months benefit in a real world experience. So, so it also gave additional insight that who are the possible patients who are not likely to do well, because this trial is a real world experience, used more patients with poor prognostic features also. So, and it did give 3 important insight that patients who had a lot of symptoms at diagnosis or had more than 3 metastatic sites at diagnosis, or those who had brain metastasis, those are the patients probably they're kind of having poor or negative prognostic factors. If you look at this symptoms at diagnosis, the hazard ratios was a 3.48 with a p-value of 0.04. It was a negative prognostic factor as far as treatment failure, early treatment failure is concerned. Similarly, for patients with metastatic disease sites more than 3 at diagnosis also was a negative prognostic factor, and those who had brain metastasis at diagnosis was also a poor prognostic factor. So this is a repeat, like the in terms of the response rates, PR, the best response was PR at 73, stable disease at 23, and progressive disease 4%, comparable with the initial published data of FLORA. So if the PFS of median PFS was 18.9 months in the trial, whereas PFS for patients who had brain mets was 13.3 months, this was also consistent with the FLORA study. And those patients who had initial symptoms had a PFS of 15.5 months. All these data were comparable with the initial FLORA study. So longer PFS in a multivariate analysis, longer PFS was noticed in the absence of brain metastasis. The median was not reached versus 13.3 months. So prolonged PFS and longer OS was also noticed in patients without symptoms and diagnosis. So not having symptom in asymptomatic patient or not having brain metastasis, these patients tend to have a longer PFS and an overall survival. A TTD of 9 months or higher was significantly associated. If a patient had a TTD of more than 9 months, that patient had a very high probability of having a better overall survival with a p-value of 0.008. So what happens at progression? This is also an important thing. So among patients experiencing progressive disease, which is the numbers in this study, 44, 21 cases underwent a rebiopsy at progression, tissue biopsy in about 14, and then liquid biopsy in about 6. What they found was MET amplification in 4, MET and EGFR in 1, EGFR amplification continued, EGFR amplification in 1, and HER2 amplification in 1. This also kind of gives an insight into what are the possible mutations, resistant mutations, and what kind of therapy can be planned in the post-operative progression. Safety in conclusion, Prasad has elicited this. We have seen the adjuvant data from the IDURA. It's a very safe drug. Nevertheless, there are some pulmonary toxicities and rash, skin toxicities. The one thing which has come out from the real world data is the incidence of venous thromboembolism. This is not much spoken in the FLORA as well as the IDURA. So venous thromboembolism rates was very common, and it was commonly encountered. There were no specific factors which showed that which patient is at risk for venous thromboembolism. So the numbers were around 10, amounting for about 7.9% of patients. There was no difference in the rates of venous thromboembolism was reported according to age, PS, comorbidity. So it was not clear as to who was the patient, who were those who were actually developing this venous thromboembolism. So this is an important insight from the real world data, showing that age, PS, comorbidity did not impact on the venous thromboembolism. So there is no difference in the survival outcome was observed according to age, comorbidity, and type of EGFR mutation. Osimertinib confirmed efficacy, effectiveness, and safety in the real world scenario. So this is very, very reassuring from a point of usage of this drug for poor prognostic group patients. So the second study was the OSI FACT. I will quickly run through. This is the introduction from the FLORA, the standard inclusion, advanced EGFR positive NSCLC with osimertinib as initial standard exclusion criteria. The baseline characters, if you look at here, I think stage 2, a few of the stage 2 patients were also involved in the study. It was a study of 538 patients. Uncommon mutation compromised about 5%, that's about 30 patients in the study. And then there were ECOG PS 3 and 4. ECOG 3 were around 4%, ECOG 4 was 0.7%, ECOG 2 was 11%. ECOG 0 and 1 was almost 80 to 85% of patients. So these are the standard baseline characteristic of the patients. Patients were also looked up from a specific point of view about the PDL1, from the PDL1 status point of view also. The study endpoint, primary was PFS, secondary was OS, time to treatment failure, and documenting the response rate and the safety profile.
Last
So
minute to
efficacy
conclude.
Yeah, so I'll quickly run through. The median PFS was 20.5 months, identical to the FLORA study. There were 182 events out of the 538 patients. So interesting to note that there were some parameters which had some negative prognostic factors. Example, the male gender, presence of malignant effusions, liver metastasis. If you have a very advanced unresectable case, these were probably kind of negative prognostic factors. With respect to PDL1 expression, the median PFS was not reached in those with TFT with a TPS score of less than 1%, and it was 14.7 for less than 49. It was 11.1 for those with more than 50%. So if you look at as I was saying, there were a few negative prognostic factors, that is the presence of effusion, liver metastasis. These were some of the negative prognostic factors from the study. Discontinuation profile, if you looked at, many of the patients discontinued actually because of disease progression, about 45%, 25% actually discontinued because of progression of other diseases. Progression because of AEs was very less. So safety profile, again, similar to safety profile as we have discussed, pneumonitis is one concern. All grades, most of the safety, most of the AEs started at about median duration of 56 days. So conclusion, the overall response rate from this real world study was about 76%. The disease control rate was 94%. The median time to treatment failure was about 19.1, comparable with the FLORA. The median time from the start of treatment to the onset of AE was 56 days, ranging from 5 to 565 days. Pneumonitis of all grades occurred in 69 patients, that's about 12%. Grade 3 or higher was seen about 5%. So this is another study which is showing that the PFS after first line osteometry in the real world practice was favorable, and discontinuation rates due to AEs was very less. The third study was published from the US. I'll quickly run through. There is very little time. This is an ongoing study actually. Only one part which from the US has been published, which is a real world experience. The study inclusion started around Jan 2000, around April 2018, and then the interim analysis June 30th, and the patients are continued to be recruited even till now. The patients will be recruited till June 2023. So here the assessment was to generate estimation, a similar treatment to discontinuation of osimertinib was the primary endpoint. Here the most important point was even the stage 1 patients were also included, probably 1 to 3A, about 16% of patients were in early stage, about 80% were in stage 4. So uncommon mutations were also part of the study. I'll just quickly show the interim analysis. 318 patients were on first-line osimertinib therapy. This was a 500-odd study. 103 patients received second-line treatment. 101 patients died on the first-line treatment. 26 patients, about 5% of them, discontinued the first line. So this was the 17.9 months, which is comparable to FLORA, is the median TTNTD, which is nothing but the next treatment, median time for next treatment or death. So it also gave an insight onto the negative prognostic factors, higher stage of diagnosis, smokers, and the Charlson morbidity index of more than 3, and uncommon EGFR mutations and number of metastatic sites being more than 4. They were all considered to be poor prognostic factors. So some of the take-home messages from the study, this study provided some real-world insights to the use of first-line osimertinib. The interim data results supported the effectiveness of osimertinib in the real world. For the long-term outcomes will be evaluated in the final analysis. Thank you. I had to rush through the last two, but I think it is reassuring to see that this drug works well in the poor prognostic features like poor performance status, even with CNS metastasis, higher stage, even in all these, this drug works very well. This is a fantastic drug. fantastic drug in this city. Thank you.
Thank you so much, sir. It was a much elaborated talk. We're gonna help the budding oncologist for sure. Next, we have a panel discussion, and the panel is on. It's a case-based discussion managing a metastatic EGFRM and SCLC, and will be moderated by Dr. Rahul Sood, who is a consultant medical oncologist, Command Hospital, Bangalore. May I have the honors to invite the panelists also? Dr. Abhay Kumar, consultant medical oncologist, Manipal Hospitals, Bangalore. Dr. Smitha S. Saldana, associate professor, Kidwai Hospital, Bangalore. Dr. Lipakshi K, senior consultant medical oncologist, Redon Cancer Center, Hubli. Dr. Mansi Khanderia, medical oncologist, NH Hospitals, Bangalore. And Dr. Rudresh A.H., associate professor, Kidwai Hospital, Bangalore. Over to you, Dr. Rahul, sir.
Right. Thank you. I hope I'm audible, visible.
Yes, sir. Slides are also visible.
Right. So I think we have a full house here. I can see everybody over here, and I'll really appreciate if they can switch on their videos so that we can have interaction, subject to obviously the network connection. So the main purpose of doing the panel discussion here is to see the experiences that we all have, and also to share these experiences. So the panel discussion is going to be very, very simple, and it is a day-to-day kind of work that we do. But there are so many things that we keep forgetting and keep missing amidst probably the rush in the OPDs or preoccupation. So let's revisit lung cancer and stage 4 lung cancer as we go forward. So the case history goes as a 54-year-old male who was a former smoker, diabetic, good PS, presented with pleuritic chest pain and shortness of breath for a period of 1 month. Oops. Okay. Right. So the CT scan of the individual was done after doing an X-ray. The CT scan was suggestive of a large lobe pulmonary mass, and also he had right adrenal gland metastasis. So a biopsy was done, which confirmed it to be an adenocarcinoma. So a lucky chap, though he was a smoker, was found to have an adenocarcinoma. Unluckily, it was stage 4 because of the metastasis. And the histopathology was subjected to an EGFR testing, and it was found to be EGFR positive for exon 21 L858R. So my first question, and I'll go in the order in which the names have been given. I'll start with Dr. Abhay. Dr. Abhay, in your practice, do you subject the patient straight away to just an EGFR testing or an NGS, or what is your practice? Do you do an EGFR al cross or do you do an NGS? Dr. Abhay, am I audible?
Yes, sir, you are audible.
Yeah. So initially, what I will do is I will do a liquid biopsy. So I will send for the EGFR testing, and simultaneously I will do NGS testing on a tumor block. Oh my God, this is something new and something. So why so, Dr. Abhay? Why a liquid and a solid? Why do you do that? No, initially, see what did AstraZeneca used to do that on so T791 mutation from liquid biopsy, that is free of cost they used to do. So that's why I wanted to use that one. All right. Okay, Dr. Smitha, what do you do in such a patient?
So usually we send for the EGFR, AL, cross, and PDL1. This is upfront.
Right.
Off late, from the last few months, we have an in-house molecular lab. So we are, for few patients, sending for NGS. But
All right.
preferably NGS is the ideal way. But most of us get it hotspot because of the limitation of the cost, financial cost.
All right. Dr. Lipakshi?
Yeah, it's same, sir. I will do EGFR, all class 1 and PDL1.
Okay.
These 4 markers as upfront.
So, Dr. Lipakshi, do you start the patient immediately on treatment, or do you wait for this report to come?
See, this patient is 54-year-old. I think wait. So I will start with chemotherapy because I don't want to wait for the reports. So if
Right.
any additional information I will get, I may add EGFR TK if it comes as EGFR positive. So only thing is whether MRI brain was done in this patient, just I wanted to know.
Right. So I will go to that. That's as we go forward. That's a question I've kept on the side. So Dr. Mansi, what is your take in such a patient when the patient comes to you?
Yeah, so I generally definitely, I mean, prefer solid biopsy and send for EGFR Alcross PDL1 because the turnaround time is quite good. But if the patient is stable, asymptomatic, we do have these good coupons panels provided by AstraZeneca for LALPATs, I think. I've used for 4-5 patients where they do hotspot of multiple mutations. So
Right.
that is also not a bad option if you have enough time and the patient is fairly stable, or maybe you're starting the patient on palliative radiation for bone meds. Meanwhile, the NGS can get processed. Otherwise, the turnaround time of EGFR Alcross PDL1 is good enough for me. I wait. I do not start chemotherapy unless the patient is very symptomatic.
So, Dr. Mansi, have you faced issues with the tissue? That is, the tissue being inadequate, and when you send for only EGFR Alcross and nothing comes, and you want to send an NGS, have you found this issue coming?
Yes, that sometimes happens. But though now, even our interventional radiologists are well aware that when it is a lung biopsy, they take multiple cores. But there is still sometimes, one of cases where it's not a very accessible lesion and you've just managed to get a small bit. That's when NGS comes to rescue, for sure.
Right. Dr. Rudresh, same problem sometimes? Tissue is the issue. And do you subject these patients again to a rebiopsy because you want to find a MET, BRAF, or do you rely on the liquid biopsy in such patients?
No, usually I think in lung, getting the tissue is one of the very difficult tasks compared to any other solid tumors.
Right.
Usually I will do with EGFR Alcross and PDL1. If anyone comes positive, I don't prefer to do. If tissue is inadequate, I am not putting the patient for another test. I will start the treatment. I will start the treatment only if patient is symptomatic initially with chemotherapy.
Right.
If
Right.
patient is asymptomatic, there is no other issues, I will be waiting for 5 to 7 days to get the report.
All right. So I'll start with again, Dr. Rudresh. Now that we've heard about, let's forget for a time being, only for a time being, that this patient was metastatic. Suppose this patient is an early lung cancer. Do you call for mutation analysis in such a patient?
Yeah, preferably I want to do it.
Right. Dr. Abe, all lung cancer mutation analysis early now?
Not all tests, only I will do EGFR.
All right. So very interestingly, I'll ask you the same question because you raked up that question regarding the liquid biopsy. So how much is the concordance between the tissue and the liquid? Because I think you would have had experience on that.
So I think it is around 70 to 80%.
Okay, right. I think liquid biopsy is the alternative to what we have. So right. So this patient was found to have L858R mutation. So I'll start with Dr. Smita. So Dr. Smita, a buffet of treatments are there. What is your choice in this patient? We've not yet done an MRI, so we are not going there as of now. So this patient, where it was?
So usually we start with either of the TKIs. So ideally the preferred is osimertinib, but usually most of us start with the first line gefitinib or erlotinib.
Right.
Afatinib personally will not use much, and dacomatinib also, because of the availability, not much.
So Dr. Smita, you have started your patient, like you mentioned, on chemotherapy while awaiting the report, and the patient is on chemotherapy. So what do you do when you get this L858R? So what do you do?
Based on the Tata study, so there was evidence that you can continue with the chemotherapy, you add the TKI, and it did show a benefit with the PFS. So if the patient was symptomatic and we had started chemotherapy, I would add the TKI along with this thing. And probably once the patient achieves after 4 cycles, after the reassessment, you can continue the TKI as maintenance.
Right. Dr. Lepakshi, your take on this. You have not started your treatment. I think that is what I got from your first question, because you'll wait for the report, or is it you also start your chemotherapy?
I will start with chemotherapy, sir.
Okay, so now you have this report. What do you do next?
So I will go with gefitinib with chemotherapy.
Right. So I think both of you agree that is where it is. So Dr. Mansi, you have not started your chemotherapy, if I'm correct.
Yeah, I generally reserve, I mean, unless the patient is very symptomatic.
So this patient is not that symptomatic. So what is your take?
So my first option, provided patient has finances, has always been osimertinib since it's become the standard of care. And I'm very happy with the results. Of course, just about 20 to 30% of my patients can afford osimertinib. But the rest I start on gefitinib. The second drug I prefer is gefitinib after osimertinib based on the tolerability. And afatinib has been pathetic. I have used it initially because long ago when during our training days we had this idea. We were waiting for Lux Lung 7 data, and we were like, no, you're doing a disservice to the patient by not offering afatinib. But we've never been able to give full doses. It always is stopped. You start at 20 and you do a disservice to the patient by giving that drug. So for me, it's osimertinib. If not that, gefitinib.
So hopefully the generic form of afatinib is less effective and less toxic now, and much cheaper also. So probably we can try. But what I wanted to ask you again was, this patient is L858R. So does that change your treatment? There is data from the Relay trial regarding the erlotinib plus the Cyramza study, and they have shown a good response. So is that important? Is the L858R mutation also important?
So it was important at one point, but osimertinib works across all mutations, including T790M. So if my patient can afford osimertinib, if my patient can afford Cyramza, they can definitely afford osimertinib. So I would still go for osimertinib.
All right. Dr. Rudresh, your take.
Yeah, patient is affordable. Definitely, I will start with osimertinib. If patient is not affordable, depending on the general condition, if general condition not that much great, I will start with gefitinib. If the performance status is very good, then I will add along with gefitinib the chemotherapy, which also shown.
Right. So why not erlotinib with bevacizumab? Erlotinib is cheap, and bevacizumab is also now a lot of what you call generic forms of bevacizumab. Why not this?
No,
will it be the second option if the patient is not affordable for osimertinib? That is what I was trying to tell you.
No, I don't think so. If patient is not affordable for osimertinib, I think gefitinib plus chemotherapy is a better option. That also has shown almost as equal as osimertinib.
Right. I totally agree. These survivals were. Dr. Abe, I think I'll come back to you now. Your take.
Actually, whether we use TKI with either VEGF inhibitor or chemotherapy, I think toxicity profile little bit different. But so even the combination of TKI plus target anti-VEGF is more toxic. So if it is a combination, I prefer gefitinib with the chemotherapy.
Right. So I think we all agree it is either the third generation TKI or it is either the first generation TKI, and we no longer use the first generation TKI alone. It is with a combination. But yes, interesting to see data maturing from other trials where L858R has been told. So rightly said, I think osimertinib is the preferred option, but there are other options which are there. And I think as we go forward, we'll keep discussing how to go about it. So starting again now with Dr. Abe again. Dr. Abe, suppose you are given these 4 choices and only given to pick one. So which will be your choice for considering the first line treatment option?
So I think for specifically in this condition, so overall survival is important because all other medications have shown. So they are all safe. They have shown PFS benefit. I think overall survival makes the difference in this particular setting.
Dr. Smita? I'll give you two choices, not one this time. I'll give you two choices. So I'll be a little biased to the ladies here. So OS is what Dr. Abhay said.
So I think, yeah, OS is important and also efficacy. Both of them are important for me.
Right.
So in stage 4, you are trying to get the best OS. So that is why the OS is important. And we also are looking for a response, because if you have a good response, that will continue forwards.
Dr. Lepakshi?
It's both efficacy and OS.
Okay. Dr. Mansi?
I would differ with my friends and colleagues. OS and quality of life, because OS anyway reflects efficacy. Quality of life is what we should aim at in metastatic setting, and it also reflects safety. If the quality of life is good, it shows that it's a safe drug. So those are my two.
Very smart. I think that's a very, very smart answer, because if the drug is safe, you itself have a good quality of life, and if it is efficacious, you have a good overall survival. So yes, so you ticked all 4 boxes indirectly. So Dr. Rudresh, similar?
Yeah, definitely. All 4 are very much important. If OS is improved and quality of life is not good, then efficacy is good, OS will benefit. OS will be more, and if it is safe, quality of life also will improve. Definitely, all the 4s are important, not one.
Yes. So Dr. Rudresh, if you see that these were what we had, the erlotinib was better than gefitinib, and somehow, as you see in the Lux Lung 7, hardly any difference between the gefitinib and the afatinib. The Archers showed that the dacometinib was better than gefitinib, but it excluded the brain metastasis. And when it comes to the osimertinib, there was a significant improvement in the survival. And I think this is something significant. But what is important to know is the brain metastasis. Majority of the studies excluded brain metastasis, especially the symptomatic brain metastasis. The Archers totally excluded the brain metastasis. So that is something that goes against the Archers study. So will the type of mutation change your choice of EGFR TKI? And probably it's a revision of what I asked you before. So I'll ask Dr. Rudresh this question. So exon 19, exon 20, and exon 21 L858R. So 3 different mutations, your drug of choice.
I think exon 19 and 21 almost the same, whatever the TKI are using. But exon 20 is a bit resistant to the TKIs. In that case, only I would think. Otherwise, exon 19 and 21 both are response to TKI. If the chance is given to me, definitely I will go with osimertinib.
Right. Dr. Abhay, 19, 21, and 20. What do you do for 20, Dr. Abhay?
Actually, so for 19, 21, there's no difference. It is osimertinib.
Right.
And 20 again, so if there is specific 20 insertion mutation, then there is newer drugs are available. But as of now, it is only theoretical, not yet available for India, like that is mevantenib. So otherwise, other rare mutations, uncommon mutations, my preference of choice is afatinib.
Yeah, right. So Dr. Abhay, just wanted to ask you, the L858R, does the chemotherapy or the Tata protocol work better than osimertinib? Any experience on that? See, because osimertinib is giving you 14.4 months of treatment, and which is very, very low as compared to the exon 21. So any data over there that you have? Otherwise, I'll ask Dr. Smita, because she would have done something like this at KTY.
No, not aware, not studied the Tata protocol.
So Dr. Smita, I'm back to you.
No, we are having a study presently, but we have not looked at the specific exon 19 versus L858R mutation. We have not looked at that.
Right.
So I think, yeah, that is your, as per your what is seen, definitely exon 19 did the best.
Okay, so what do you do for exon 20?
Even the Tata study, I think they have not subcategorically mentioned about the different EGFR mutations.
Right. So exon 20, Dr. Smita, what do you do?
As of now, we are giving chemotherapy, or osimertinib only for reimbursement patients.
Right. Dr. Lepakshi, your take, mutations?
Yeah, for exon 19 and 21 pan generation TKI. For exon 20, it is osimertinib.
Okay. So what is your drug of choice? Suppose you start these patients on osimertinib and the patient progresses. What is your way to go forward in the second line in such a patient? Again to you, Dr. Lipakshi.
So if the patients progress on osimertinib, then I will prefer chemotherapy.
Right.
And if they are affordable, then based on IM power, you will add atezolizumab with bevacizumab also.
Right. Dr. Mansi, first line osimertinib?
So generally, if it is
or do you
just
sequence it?
No, I use first line osimertinib as far as possible if the patients can afford, and if there is just metastatic or very minimal progression, we try to treat the local site and continue osimertinib as far as possible. I've tried to drag a few patients like that for more than 6 months also, and after that it is an open house. You can pick whatever. So I tend to pick chemo, especially PEM carbo, because it's well tolerated. That's the very reason I avoid using chemotherapy upfront, because it's a well tolerated regimen which we can use later on. So
do you continue your osimertinib with the chemo, or do you stop the osimertinib?
No, then I stop. Once I switch, I stop.
Right. Dr. Rudresh, your take, progression on osimertinib, second line?
Yeah, it is depending on the number of lesion and the symptoms. If very few lesions, definitely I will treat with local therapy and I will continue osimertinib if I am doing. Otherwise, I will usually switch over to chemotherapy, as PEM carbo is one of the least toxic drug what I come across. Very few toxicity.
Right. So there is data regarding that C797S mutation, which is there, which causes resistance to osimertinib, and there is some data that in such patients, geftinib somehow works. So I think worth seeing. So this slide shows that the osimertinib has the highest overall response rate and the median. So how important is the overall survival? And I think you've all answered. So I'll just skip to that. And as you can see from the FLORA trial, the overall survival was best with osimertinib, and the Archers also showed an improvement of that. But most importantly, it did not have patients with brain metastasis. So something that is against the Archers trial and decometinib. So this was the phase 3 trial. So now coming to the point which was there. While choosing the EGFR TKI, can you ignore risk of developing CNS metastasis? We know that CNS metastasis may be present in 25% of individuals and 50% as lifetime risk. So I'll go to Dr. Rudresh only. So Dr. Rudresh, important?
Yeah. No. I will not ignore. It is one of the very important site of medicine in CLN. I always keep it in mind.
So Dr. Rudresh, asymptomatic brain mets, only osimertinib, or would you like to irradiate this patient? Secondly, symptomatic brain mets, only osimertinib or radiation?
If patient is asymptomatic and there is no other issues, I will continue with osimertinib. I will see for the response. If response is good, I will continue. If patient is symptomatic, usually if possible, stereotactic radiosurgery or local therapy, if possible, I will do it. Then I will continue with osimertinib.
I think bang on you are. Dr. Abhay, I'll take your call on this. Though I think you should agree with what?
Yeah, definitely. If patient is asymptomatic, then we'll continue osimertinib. So only if patient is symptomatic and limited metastasis, SRS. Otherwise, if it is extensive metastasis, then whole brain RT.
So Dr. Abhay, are the number of brain mets important? Whether they are suppose he has multiple brain mets and patient is asymptomatic, is that important vis-a-vis a single brain metastasis? Is the number of brain mets important?
It's not, but it's only important for the treating it, just for to prevent the neurotoxicity. If the number of, even if there is a multiple brain metastasis, if the patient is asymptomatic, then still we can treat with only osimertinib. There's no need to hurry to treat the brain lesions with the RT. Only thing is that it makes difference only whether, if patient is symptomatic, whether we are able to preserve the other normal brain area, whether to do by SRS or whole brain RT.
Right. Right. So I'll come to Dr. Smita. Dr. Smita, how has been your experience using osimertinib with asymptomatic brain mets, and then you've not given RT to these patients? How has your experience been?
So usually the osimertinib is having a good CNS penetration, and usually we see very good response. So for
Right.
patients who are not, symptomatic, and they usually the progression of the development of the brain mets is delayed for a longer time. And even patients who have had asymptomatic patients with brain mets, so they also have responded well to osimertinib. But
Right. Right.
at some point they will progress.
So any patient, Dr. Smita, because you see so many patients at Kidway who you started on osimertinib, and within 2 months the patient has progressed in the brain. I had one, so that is why I really want to know.
No, we didn't have any osimertinib started patients who had progressed on only the brain. But
Right.
yeah, there was another reimbursement patient, which the
Right.
patient had a leptomeningeal disease. And
So
I
that
think
is
that,
always bad.
yeah,
Yes.
that was a bad thing.
Yeah, that is always bad. Dr. Lepakshi, your take on the same question.
Yeah, in the asymptomatic brain mets, so I will consider osimertinib only.
Right. So how long can you keep these patients asymptomatic with brain mets with osimertinib? How which has been your longest patient?
It's almost
They will
about
progress eventually. They
yeah.
will progress in the brain eventually. We know that. So which has been your longest? I'll tell you, I had a patient who progressed within 1.5 months. That is my shortest, I know. So
So it's about 16 to 18 months.
oh wow, wonderful, wonderful. I know that there is data, and even the westernized data says that these patients can be kept for anywhere between 12 to 18 months. Dr. Mansi, your take?
So I just wanted to add one point. There is some data where when symptomatic meds or when there is mild progression on 80 mg, you can increase the dose of osimertinib to 160 mg. Okay. I had a patient where I was thinking of doing that, hoping that AstraZeneca will give at the same cost, but then it was doubling and they couldn't afford it. But there is good data on that. And another one of my patient, I mean, fortunately or unfortunately, they reached me after a surgery for the brain meds. They had a solitary brain, she had a solitary brain lesion, and generally I don't send for metastatectomy, but she underwent that and she came back and she's doing really well.
Right.
So on osimertinib.
We have all heterogeneous patients. I have never tried a 160 milligram dose ever. I don't think anybody in our panel would have also. But yes, something for as we go along, toxicity is keeping in mind.
To add to Dr. Mansi, I think there was one that leptomeningeal patient. I said no. So that particular patient, when I had gone through the review of literature for leptomeningeal, they recommend 160 mg. Osimertinib in a BD dosage.
There is a data Bloom study is there. In that data they used either weekly erlotinib 10 times the dose or the 160 mg of osimertinib. So it has shown good improvement, good response rate. Nearly around 70% response is there.
So Dr. Abe, did they give some intrathecal injections also to these leptomeningeal diseases, or did they incorporate RT also to such patients?
I think only they continued osimertinib.
Okay, what something very wonderful I have not come across. I think something to learn from this. Right. So Dr. Rudresh, a question for you. Do you routinely do a brain MRI for all stage 4, even if not symptomatic? I think the answer should be yes. Dr. Rudresh, am I audible?
Yeah, most of you are asking routinely for all the lung cancer patients?
All stage 4s?
Not much.
NCCN recommends anything beyond stage 3 you should ideally do.
Yeah, I know, but most of the symptomatic patients we are doing.
Okay.
But asymptomatic, some patients, if PET CT scan not done, if there is no other lesion, we may think. Otherwise, no.
Dr. Abe?
So actually, ideally should be supposed to be done, but when I will do PET CT scan, I will see the lesions in the brain. So in PET CT itself.
Yeah.
So
If
not
PET CT
routinely
scan
for
shows
every
some
patient.
lesion, PET CT scan pick up some lesion, then I will go for MRI brain.
Okay, Dr. Smita. Dr. Smita.
Usually, we should do you asking a question about brain MRI, right?
Yes, yes. Are you doing it for all your
Yeah,
patients, stage 4?
mostly not for everybody, but yeah, almost more than 60% we are doing it.
All right. Yeah, yeah. Right. So NCCN says you should, and though we also don't do it in all, but we try to get a CT with a contrast in majority of our patients, and at least try to do that. But because we need to decide on the treatment in the base, because lung mets are an important factor when we start our treatment. So I think we should try to at least do a CT scan for our patients. So this was the various trials. I'll not harp into that because I want to know from all of you. So hypothetical scenario, and I'll go to Dr. Lipakshi. Would PDL1 positivity favor in starting IO in this patient upfront? So we have the data from the pair of Pacley. I think it was Pacley Carbo and the IO.
Dose.
Yes. So the patient fortunately has 2 mutations, the EGFR and the IO. So IO now for this patient.
गोल गोल हाँ हो गई नहीं ये दूसरी है चेक वाली डिफरेंट है
could you mute excuse me, could you mute the people in the background?
So if the patient progressed on osimertinib,
no, I am saying first line hypothetical.
No, we don't have data.
So the patient was started on PEM carbo and you suddenly get a PDL1 and EGFR. So would anybody start an IO for this patient in the presence of EGFR? No. Dr. Mansi?
No, EGFR takes precedence.
Yes. So I think you're bang on, because we've seen from all the studies, if you have a target, the IO is defeated. So you first target that therapy rather than go for the IO. The IO can always be kept for the subsequent lines. So we know
and
tumors
one thing, what is the percentage of both being positive? I think those are all mutually exclusive.
No, I don't think it is now the factor
Very
for
less,
PDL1.
maybe less than 1%.
No, yeah. So I don't know the percentage, but PDL1 with EGFR is not necessarily mutually exclusive. Yes, EGFR ALK maybe, but I don't think so PDL1. I would love to know from the house.
I have 2 patients whose, I mean, generally when you want PDL1, it will not be positive in squamous but I have 2 patients whose EGFR was positive and PDL1 is more than 50%. So
I have 2 patients myself. I have 2 patients myself. So that is why I kept this question also. And I started them on chemo and added Geftinib. It works easy on the pocket of the government. So that is what I did. So I think, Dr. Abhay, they are not mutually exclusive, because we had also done a study in my previous place where I was at Delhi Army Hospital, and in NGS we found them to coexist. So yeah.
Definitely, PDL1 is not a mutually exclusive with any oncogenic drivers.
Right.
And also there is a data that when you use osimertinib post IO, there is a more toxicity with osimertinib. Even they won't recommend also.
Absolutely, yes, absolutely. There is definitely. So you should never do that. You should use your EGFR upfront. So how important is the safety profile, Dr. Abhay? Do you keep that in mind?
So most of the first generation and third generation are most safe. Commonly we see come across is sometimes rash with the Geftinib, most commonly what we use that one. So but the rash is a little bit more common with the Erlotinib. We have not seen any much diarrhea with the whether first generation or third generation. And also what they mention is regarding QT prolongation and not come across in osimertinib group. So osimertinib is more well tolerable. But I have seen a lot of problems with the afatinib. So definitely So one of the patient who has got very uncommon mutation, that's multiple 2 mutations were there. That patient I started on 30 mg, but patient is tolerated. So patient I escalated to 40 mg. Patient is tolerating. So, but the main problem issue is regarding the rash and diarrhea.
Right. So, Dr. Smita, osimertinib safe to use, or is there any subset where you have not used osimertinib because of the toxicity and changed over to something else?
Most of my patients who have been received osimertinib, very safe, relatively well tolerated.
Right.
So I am not aware of any that much of toxicity.
Dr. Lepakshi?
So most of the patients are well tolerated, but one of my patient had grade 2 ILD.
Okay.
So that resolved with steroids.
Okay, and then you restarted the patient on osimertinib in the same dose, or did you escalate the dose from a lower level?
So patient itself was taking an alternative day.
Okay.
80 mg
okay,
alternate day. Yeah.
Right. So you raised a very interesting point, this alternate day regime. So Dr. Mansi, I heard you saying you're not happy with the afatinib and decometinib. So have you ever tried the alternate day of these drugs? The diarrhea and all is considerably low if you give them alternate day.
But what's the point if you don't? They are supposed to be efficacious at full doses. So I still stay away from them.
Right.
With osimertinib, rightly said by Dr. Lepakshi, if there is a already evident ILD, you should not be starting it. I lost one patient, not with osimertinib, with crizotinib. She had metabolic CR, but she had horrible ILD, and then from then on, I keep checking for ILD before I start any targeted therapy. So.
Yeah, I totally agree. Crizotinib, ILD, as well as pulmonary edema patients do very badly, some of them. So, I totally agree. So dose reduction, as you can see, was lowest in the FLORA trial. So a very, very easy to use drug is what osimertinib is. And so Dr. Rudresh, quality of life, does it matter? You said yes. You said all 4 of them.
All 4 are important.
Yes.
If the efficacy is good, OS will improve. And if it is effective and if it is safe, definitely quality of life will improve.
So Dr. Rudresh, the quality of life is best with the first generation TKIs.
My experience with the first generation is maybe around 8 to 10 years. So I never come across a lot of toxicity with gefitinib or mostly gefitinib, except I stopped the tablet in a year, maybe 1 or 2 patients because of the toxicity with gefitinib. Osimertinib, we started using maybe 1 or 2 years. So we have to wait.
Right. I think the quality of life, we all agree, is the best with first generation, but we know that they cannot work in alone. They have to have a partner along with that. So,
Dr. Rahul, sorry to interrupt.
No, please.
I would not agree that both are, first generation is better. I think they are equivalent. And unless you are counting financial toxicity as quality of life, I think...
Yes, that I kept it separately, but definitely when it comes to financial toxicity, then the thing shifts definitely towards the first generation.
Yes. But if you see in the FLORA trial, the quality of life was not worse with osimertinib. So I think, and even in my experience so far, whichever few patients I've used, it's okay. It's fairly tolerated. I've not seen a problem with the tolerance of the drug as such.
All right. Because Dr. Murli has scared us regarding the venous thrombus, and we are already scared of the venous thrombus with the ongoing COVID. So that's why I thought I'll just put it. I think osimertinib is something that we have worked with. So do we start osimertinib in the maximum possible dose, or do we start it in a lower dose and escalate? Dr. Abhay, your take?
No, full dose only.
Full dose, right?
Most of the times, what happens when we start the patient, they will come after 6 months, 8 months, like that. The drug.
Right. Right. Dr. Smita, full dose?
Full dose.
I don't know. Paying patients, they run off when you tell them the cost of the full dose. So, Dr. Lepakshi, have you tried? Yeah.
No, it's full dose only.
Right. So, Dr. Mansi? Do they ask you the cost of the full dose?
I don't give any other option. I mean, it's either that or first generation. I don't give them an option of alternate day dose. So it is full dose, and of course they keep my patients unfortunately keep calling me every month if there is any discount, if there are any new offers. They don't disappear at all.
All right.
And there is no. I wish there was a patient assistance program where after 10 months or 1 year there was some discount like our CDK4/6 inhibitors, but no, these patients don't get that.
Yeah, Astra is listening. So Astra, something. Dr. Rudresh, full dose?
Yeah, full dose only. If they are not affordable, I will not start on.
You will not start. Okay, so wonderful. So you led me to my last question. So in these patients, do you not start the patient on anything, or would you like to sequence these patients and give them something else and then probably osimertinib? So when would you consider sequencing approach? Dr. Rudresh, you there?
Yes. Sequencing of TKIs.
Obviously, yeah. So we are not giving osimertinib here first. So when will you consider sequencing the TKIs?
So if first line, if I'm using gefitinib or erlotinib, I will, if patient progresses, then I will check for any specific mutation.
Right.
Then depending on that, I may sequence. Otherwise, it is the same for all.
Okay. So Dr. Abhay, finances, is it an important thing? For sequencing, you can start the patient on afatinib and probably at least keep the patient with yourself and then give osimertinib in the second line. What I basically mean to say is the cost.
Yeah, definitely sequencing is important, but more important is first all patients will give the option of osimertinib. Definitely if patient is not affordable, then we keep the option of sequencing. So even though in sequencing also, so there is a 10 months the PFS benefit is there, even though the patient has to use for minimum of like 10 months. So I have very bad experience in the second line, osimertinib. So most of the times what happens, 30 to 40% patient may not reach to second line only. So that's why it's always better to use the best drug in the first line.
Absolutely, I agree. So Dr. Smita, sequencing, you get T790M in the second line when the patient is treated with either first or second line. So would you like to sequence, and do you discuss the sequencing with your patients?
Usually, see, the patient is affordable, upfront go with the osimertinib in the first line, and then at a later date you can always challenge them with chemotherapy. For a patient who is not financially sound, always will go with the first line and keep osimertinib as a option for the T790M mutation or at progression.
Right. So you'll agree first line osimertinib has better result compared to sequencing strategy. Do you agree with this?
Agreed with it.
Yes.
But only thing is, I think if this is the ideal situation, so we are not in the ideal situation in the practice.
Suppose you want to sequence Dr. Lipakshi, what will be your sequence in this patient?
So either erlotinib with bevacizumab followed by osimertinib if T790M positive, then chemo.
Right. Dr. Mansi, sequencing this patient.
So as I've said earlier, osimertinib upfront. Sequencing I only reserve for patients who are poor, and I tell them that maybe a year down the line, maybe the cost of this drug will go down and then you will benefit from this drug. That's the only time when I choose sequencing.
Right. Dr. Rudresh, sequencing, suppose.
Yeah, definitely I will, if the affordable osimertinib is the first line.
Right.
Then if they are not affordable, then gefitinib.
Right. So I think we do agree that patients, by the time they come to second line, they are already drained out physically as well as many times financially, and their motivations are not that great. So it is always better to throw your best foot forward and give osimertinib in these patients. And this is what the study was. And only very few received second or third line, considerably lower numbers receiving the second line. So the geotag study, which is told about afatinib, I'll not go into this because of paucity of time. And these are my conclusions. And we all know about osimertinib, the PFS and the OS benefit, especially the CNS. And even after 3 years, 28% of the patients remained on osimertinib. So this is something we can take pride in. So osimertinib has a favorable toxicity like we all discussed, and despite prolonged exposure also, we know how to manage these toxicities. So this is my conclusion, and this was my last slides. And thank you very much to all my panelists, Dr. Abe, Dr. Smita, Dr. Lipakshi, Dr. Mansi, and Dr. Rudresh for being a part of it. If there are any questions for any of them, I think they'll be happy to take it.
So I will ask one question.
Right.
So everybody. So in lung cancer adjuvant chemotherapy, stage 1B, so everybody will use adjuvant chemotherapy or not? That is one question. And second one is, in adjuvant, what is the best protocol you use? Which chemotherapy?
Right. So if I can answer, we tried to give adjuvant chemotherapy as per the ANITA trial, but we do not give vinorelbine to our patients. We usually use our conventional paclitaxel plus platinum based as adjuvant. That is what we do, and we do it for the high risk patients. And the definition of high risk, I think, in early lung cancer is different from different people. But we give it especially in the high risk patients. I think Dr. Mansi, I can see.
I agree with you, Dr. Rahul. So,
right.
Though I do tend to give pemetrexate also,
right.
But otherwise I agree.
Right.
I think number of cases detecting stage 1B, I think very, very less. Maybe in year 1, maybe 2 in correct, no? Not very.
With COVID, fortunately, it has increased because of the screening protocols. We did pick up in the first and second wave a lot of stage 1 lung cancers, which I've never in all my life picked up.
Yes, we've all come across this. I think we picked up so many, and I think the role of low dose CT, where we've got it done in our COVID patient, should come into practice. And I think our first speaker, Dr. Narayanan, also mentioned about it. Because of, I think, finances, because of awareness, and because of majority of the people not having the access to low dose, they are getting missed. And I think this is something that needs to be incorporated. We've learned from COVID and picked up so many cases of lung masses. And I think this should definitely be incorporated. This should be a screening test. Right. So,
thank you, sir. Thank you, sir. Thank you, all the panelists. And Rahul, sir, I request you to kindly to give a vote of thanks.
Yeah, so I think I have already given a vote of thanks. So again, I start from the back. I thank Dr. Rudresh, Dr. Mansi, Dr. Lipakshi, Dr. Smita, and Dr. Abe for being a sport and listening to my boring questions and whatever. Thank you so much for interacting. I've learned a lot from the panel. I would like to thank Dr. Murli for his talk. Again, Dr. Prasad Narayan, he had to leave. He messaged me, he had to leave. And Dr. Narayanan, who's our young budding chest physician, to consent for giving a talk. So thank you so very much. And thank you to the organizers, that is Horizon. And thank you to AstraZeneca, who have always helped us out in this. And lung cancer will always remain a challenge. And that is why we are so excited to learn from each other on those fronts. And that's all from my end, and over to the organizers.
Thank you, Dr. Rahul. Good night.
So indeed, we had a wonderful. Thank you. Thank you. We close the meeting, sir. Thank you, sir. Hello, support team. Can we now close?
Sure, sir.
Yeah, we can close the meeting for everyone now.